Hello, so on the video you will have seen me explaining asthma to the patient that I was sitting with, and you will have seen me drawing things on a piece of paper. So I thought it'd be useful to show you what I'm showing the patient. The first thing I talk about or talk to a patient with is what their understanding of asthma is. So I say to the patient, do you know what asthma is and how your inhalers work? And the majority say no. Some will say yes, but it's still worth running through just to make sure they've got the right message. So I talk a little bit about lungs, I talk about where they are, how big they are, and I talk about the fact that in asthma it's not the tissue that causes the problem, it tends to be the tubes running through the tissue. I then, on a piece of paper, just draw a circle and say this is representing your airway, and explain it's not to scale or size, it's just to give them an idea of what's happening. So I draw the airway to begin with, and then I draw the mucous membrane. So I draw another circle inside, as you can see in a sort of pinky colour here, and I say this is the mucous membrane that lines those tubes, and it's there for a reason. And I explain to them a little bit about mucous membranes. I explain it's the same up inside your nose, and I explain that it's there for a reason. It's for warming air, making sure that the air is humid, etc., etc. You know these things to explain. And I explain that this is what you would see if you looked at the airways of somebody that doesn't have asthma. I also explain, really importantly, that if you looked at the airways of a patient with asthma that is really well controlled, this is also what you see, so you'd see no real difference. And I explain that this is where we're aiming to get all of our asthma patients, so they've got really well controlled inflammation in their lungs, so their symptoms are better. On each of these diagrams, I'll just put a little arrow afterwards so you can see which bit I'm pointing to with the patient and which bit I'm talking about. I then go on to talk a little bit about inflammation in airway and the importance of inflammation, and the fact that the inflammation is really the problem that is causing all of the symptoms, or the majority of symptoms in asthma. So I talk about the inflammation that sits within the mucous membrane. So I explain that the lungs become inflamed, and the part of the lungs that become inflamed is this lining, this mucous membrane. And when it becomes inflamed, it swells, and because it's in a tube, when it swells, it's got nowhere to go. So what it does is it swells into the airspace, reducing the openness of that tube, reducing the sort of the volume of that tube, causing difficulty for the patient to breathe. So as I say, these are the bits that I'm pointing to for the patient. I then go on to talk a little bit about bronchial smooth muscle. So I explain there's a muscle that sits around the outside, and I explained that with smooth muscles, you can control them a little bit, but they're mostly under the control of your nervous system. So they do things without you thinking about it. So I explained that we can hold our breath, or we can make ourselves cough, so we've got some control over it. But if we hold our breath for too long, our brain will override that and make us breathe. And if something goes down the wrong way, we cough. So I explain a little bit about twitching. But I then explain that when we've got this inflammation in the centre, when the lining of the lungs is angry, as we see in asthma, what it does is it makes the airways, the muscle around the outside, really twitchy. And then when it comes into contact with something it doesn't like, so I explain a bit about what that might be. That might be going from warm to cold, it might be smoke. And this is a really good point to talk to your patient about triggers, because you can ask them, is there something you know that sets your asthma off? So when it comes into control with something that it doesn't like, that twitchy muscle goes into spasm, and you have to use your hands here, and it shuts down on the airways, and it further reduces the airspace in the middle, making it more difficult for the patient to breathe. And I explain that this is when the patient may feel more short of breath, may feel more wheezy, may cough more, so that they can associate that with their symptoms. So there are my pointing arrows for you to explain what's going on. The next bit, so once you've built that picture of what asthma is, this is your opportunity to explain how the medication works. And I always start with the preventer, because, as I say, we're trying to promote the importance of the inflammation more than anything. So I explain that when they take their preventative inhaler, so often we do it in colour, so often it'll be when you take your brown inhaler, what this does is it settles down that inflammation, it shrinks back that mucous membrane, and it takes it back to a more normal looking mucous membrane. I explain that when you take these preventative inhalers, you do not feel them working. You don't take it and suddenly feel fantastic, but it's there working in the background, and it's really important that it is there settling things down. I explain it doesn't work immediately, so when you initially start on a brown inhaler, it'll be a few days before you notice any benefit at all, and a few weeks really until you're feeling the sort of maximal benefit of it. And I explain that it is then really important to keep taking that medication to keep the airways in that really nice healthy state. So you've built the picture and the importance of the inhaled steroid. Then I talk about rescue medication, about bronchodilation, and I say that if the airway is twitchy at any point, this is where your blue inhaler works, what your blue inhaler does is it very quickly relaxes the spasm in that airway, opens it back up, and leaves it in a more normal state. But it only works for 4 hours. But again, it's the importance of saying, if we get this inflammation right, then you are less likely to need to use rescue. You may occasionally still find that it happens, but it shouldn't be a regular thing. So I hope that has helped to explain how I explain things to patients. You can use pre-drawn diagrams. Personally, I find them sometimes a little bit too scientific looking for our patients. But importantly with this, you can build this picture and the story as you go along, so the patients are really understanding each stage of it. The other thing you can use are the asthma lung demonstrators, so you can get 3 parts to the demonstration set. One is the normal airway, one shows the airway with inflammation, and one shows the airway with inflammation and bronchospasm. So those are also really good to use. So I hope that helps for you to explain in a fairly concise way and a fairly consistent way to patients what's happening.